that, well, you have dengue fever, but if you face these problems or if you notice these issues, you must rush to the hospital or to the nearby physician. So these are the warning signs. Again, bleeding in any form, black color stool, heavy menstruation. For the female, heavy menstrual bleeding is very vital to spot. Sometimes female complaining of starting early menstruation, which is also an alarming sign, and the other warning sign I have mentioned already. So what about group B? The warning sign, patient admitted, you have to give a maintenance fluid therapy. So the most easy to calculate is the Holiday-Sager formula. So according to Holiday-Sager formula, if a dengue patient is admitted with group B, you have to calculate the fluid, how much fluid the patient will get in 24 hours. So for first 20 kg, 1500 ml, then for each kg, 20 ml you will add. So say for example, in an 80 kg man, for first 20 kg, 1500 ml, and then remain the 60 kg into 1200 ml. So the maximum amount of fluid the patient should receive is around 2.5 liter in 24 hours. And all of you know that we do not keep the patient on nothing by mouth, so it is always better to be conservative during fluid management. So you can give at least say around 2 liter to 2.5 liter in 24 hours. So this fluid is required only for 2 to 3 days. That is the critical phase. Usually after that the patient doesn't require any fluid. Which fluid you need to answer? Crystalloid versus colloid. There are head-to-head trials, and the trial said that crystalloid is good enough, but in sometimes you need colloid when you are managing a case of compensated or decompensated shock. What about the compensated shock? So the management of compensated shock is very critical and labor intensive. So dengue shock syndrome is not a condition where you will refer the patient. If you refer the case, the patient will die in the ambulance or coming to the hospital. And that is what happening in the country actually. So dengue shock syndrome you have to manage on site because you will get only 4 to 6 hours to manage the critical stage. So if there is a compensated shock, you will start the fluid 5 to 10 ml per kg. That is the fluid bolus which we charge. So you will take normal saline, you will give a bolus charge 5 to 10 ml within 1 hour. If there is no response, you check the CBC, you go for second bolus. Second bolus again, it is 5 to 10 ml in 1 hour. If there is no response, you have to do blood transfusion. So that is the step actually. So the first bolus, if there is no response, you give second bolus. During the second bolus, if you found that there will be a huge amount of fluid you need to give within 1 hour, then you can choose a colloid. Because if you choose a colloid solution, that is a plasma solid expansor, you can avoid giving high amount of fluid. So in the second charge, if the patient not respond, you have to go for blood transfusion. But in most of the cases, my dear colleagues, in most of the cases, after giving the first bolus, the patient will respond. So if the patient respond, then you have to step down the fluid therapy, 7 ml per kg in 1 hour, 5 ml in 1 to 2 hours, 3 ml in 1 to 2 hours, then put the patient into maintenance fluid as per the Holiday-Sager method. The same happens in the compensated shock. You have to give large volume of fluid within half an hour. So 10 to 20 ml per kg within half an hour. There is the role of colloid actually comes. So we are actually misusing colloids. So if there is decompensated shock, BP is non-recordable. You have to give the first bolus in 10 to 20 ml per kg within half an hour. If there is no response, check the hematocrit. You go for second bolus with colloid. If there is no response, you have to give blood transfusion. So this is all been taken from the national guideline. But in most of the cases, it responds. So you have to step down, as I said before. 10 ml in 1 hour, 5 ml in 1 to 2 hours, 3 ml, and then Holiday-Sager formula. You have to put the patient in maintenance fluid. What are the indications of blood transfusion? So WHO is now moving from platelet transfusion to the concept of blood transfusion. If you really want to transfuse, you do transfuse blood, not platelet, because blood has some other essential components like albumin, which might help you to manage the plasma leakage. So the blood transfusion indication is the refractory shock. As I have said, if the shock is not responding after fluid challenge, you have to go for blood transfusion. If there is any overt bleeding, you have to go for blood transfusion. If the hematocrit suddenly drops less than 20% of the baseline, you have to go for blood transfusion. And of course, if there is any metabolic acidosis, confirmed by ABG, you can go for blood transfusion. There is no evidence to support the use of blood concentrates, platelet concentrates, fresh frozen plasma, cryoprecipitates and others, because that will contribute fluid overload. What about the platelet transfusion? Platelet transfusion is only indicated if there is very severe thrombocytopenia. What is the definition of very severe thrombocytopenia? So the Americans believe that if it is less than 20,000, you can go for platelet transfusion. But the British guidelines say that if it is less than 10,000, you can go for platelet transfusion. In our BSMMU setting in the medicine department, we always follow up, we wait until 10,000. So until 10,000, we do not give any platelet or transfusion if there is any no bleeding manifestations. Yes, of course, if you go for any surgery, like emergency C-section, or if there is any road traffic accident where you have to go for major surgery, the platelet count should be 50K. So in that case, you can go for platelet transfusion. Steroid, the role of steroid is controversial. You can use steroid only in certain conditions like dengue myocarditis, dengue encephalitis, dengue optic neuritis, in those cases. And of course, in pediatric population, there are two phase 3 RCT where they have been used methylprednisolone in the pediatric population when there is refractory shock. Otherwise, there is no convincing evidence of using steroid. You can go for those two papers who are interested why steroid doesn't work in dengue infection. What about the L-thrombopag? Well, only one phase 2 RCT comprising 30 patients will happen, funded by Incepta Pharma. Interestingly, that is happened in Bangladesh. So there is no convincing evidence of using L-thrombopag which can save severe dengue cases. So we need robust RCTs where thousands of patients should enroll. Then we can tell about the role of L-thrombopag. I am not going in details about dengue vaccine because Madam has already enlightened those, but you really need to do endemicity assessment before taking any decision on dengue vaccine. We do not even know the estimate of the disease burden and how we will do the endemicity assessment. So we should not be in any hurry of taking any decision regarding the dengue vaccine. Thank you very much, respected audience. I am happy to take questions.
Years before, but we are not prepared, what I feel. And unfortunately, I have had encountered a case of expanded dengue in my family who has severe neurological disability. And he was in ICU for one month. And then he was in ward. Now it's about 2 months till he is having neurological disability. He's just 11 years old. Very sportive boy of my family. Anyway, and I hope that you are having such members in your family. I pray for everyone that they are recovered with zero disability, and hopefully by our all effort will overcome this dengue fever. And thank you very, very much. Joy Bangla, Joy Bangla. May Bangladesh
systems, especially the neurological system or the features of anticoagulation in some cases, anticoagulants. And the cardiac, the follow-up solutions, you can use immunotherapy based on 40 plasma analysis. For the follow-up, we have to see the vital signs and we have to get the laboratory parameters, shock or organ impairment like whatever it is. For the practical purpose, intensive care unit. So the stable patient, stay home, take plenty of fluid, and if there is no comorbidities, just to follow the vitals so that
তারা হাসপাতালে আসবে। একটা কথা কেউ দেখেন নাই, বাড়িতে কেউ নাই, একার জ্বর হয়েছে, ওই লোকটা যেন হাসপাতালে চলে আসে তাকে রক্ষা পাওয়ার জন্য। আমার কাছে খুব ভালো লেগেছে যে এটাও একটা ব্যাপার যে তার কোন সিচুয়েশনে সে আছে, কোন সময় হাসপাতালে আসবে, বাড়িতে কেউ নাই। আজকাল আমরা একটা গল্প সেদিন শুনেছিলাম যে উত্তরার একটা বাসা থেকে 3 দিন না 4 দিন পরে গন্ধ বেরোনোর পরে একটা মৃত ব্যক্তিকে বার করা হয়েছে। তার অর্থটা হলো অনেক লোক কিন্তু এখন কানাডায় আমেরিকায় চলে গেছে, দেখার কেউ নাই। সুতরাং সেই লোকগুলোর জন্য আমরা এখানে একটা ব্যবস্থা আমাদের আছে, পিলিয়েটিভ কেয়ার। আমরা এখানে কেয়ার যেভাবে রেখেছি, আমরা বঙ্গবন্ধু বিশ্ববিদ্যালয়ে মনে করি এই ধরনের চিকিৎসা আমরা সামনের দিকে এগিয়ে নিতে সক্ষম হব। এবার ডেঙ্গু ম্যানেজমেন্টে বোধহয় বঙ্গবন্ধু বিশ্ববিদ্যালয় গভর্নমেন্ট সহ যারা কনসার্ন তাদেরকে আমরা সচেতনতা করার জন্য কয়েকটা সেমিনার করেছি, 2-3টা হয়েছে, আজকেরটা সহ চতুর্থটা। আমি মনে করি যে আমরা এভাবে জনসচেতনতা বৃদ্ধি করে দেশের মানুষকে স্বাস্থ্য সচেতন করব এবং বিভিন্ন রোগ ব্যাধি থেকে তারা মুক্ত হন, এটা আমরা চাইবো। এবং মেডিকেলি এডুকেটেড হলেই, মেডিকেলি সচেতন হলেই, অনেকেই আজকাল কিন্তু সচেতন হয়েছে বলেই আমার এখানে 8 থেকে 9 হাজার আমাদের সার্ভিসও দেয় এবং রোগী আসে। আমি স্ক্রিনে দেখেছি যে তারা বোধহয় 150 থেকে 200 রোগী পার ডে ওপিডিতে দেখে। এগুলো কিন্তু সার্ভিস দিচ্ছে বলেই আসে। অনেক ডিপার্টমেন্টেই রোগী উপচে পড়া ভিড়, আমি মনে করি এটা আমরা সেবা দিচ্ছি বলেই এটা হচ্ছে। তো আমি আপনাদেরকে আজকে এখানে উপস্থিত থাকার জন্য এবং আমাদের সেমিনারকে সফল করার জন্য মিডিয়ার যারা কর্মকর্তা এসেছেন তাদেরকেও আমি ধন্যবাদ জানাই যে আপনাদের মাধ্যমে দেশের মানুষ আরও সচেতন হোক এবং সরকারকে সহায়তা করুক যাতে ডেঙ্গুতে আর কোনো মৃত্যু না হয়। সবাইকে অনেক অনেক ধন্যবাদ ও কৃতজ্ঞতা জানিয়ে এখানে শেষ করছি। খুদা হাফেজ। জয় বাংলা, জয় বঙ্গবন্ধু, বাংলাদেশ চিরজীবী।